Hello everyone. For today's topic, we will be discussing about the intestinal and commensal amoeba as our first topic in medical protozoology. These are the required readings for this topic, and these are the parasites that you should know, at least in terms of their parasite biology, life cycle, epidemiology, pathogenesis and pathophysiology, clinical manifestation, laboratory diagnosis, treatment, and prevention. So these 8 key information, you should know this by heart. Now, the amoebas are unique because they are the unicellular eukaryotes. And the most important feature that separate amoebas from other groups of unicellular protozoa is the means by which they move. They have pseudopods, which are the extensions of cytoplasm to function for locomotion. Other protozoa have different mechanisms of movement, just like in ciliates, they have, by the name itself, they have these ciliations. For the flagellates, they have the flagellum. Amoebas generally have two forms. They have trophozoites and cysts. So, in trophozoites, they form, this is the form that feeds, multiplies, and possesses the pseudopods. They are delicate and fragile. For the cysts, they are the non-feeding stage, characterized by a thick protective cell wall designed to protect the parasite from the harsh outside environment when deemed necessary, and they contain this thick outer covering. Now, the trophozoite is the one that is metabolically active, while the cyst that is the metabolically inert. We have two important terminologies for amoebas. When we say excistation, this is the morphologic conversion from the cyst form to the trophozoite form. Okay, in summary, that's the cyst to form a trophozoite, which occurs usually in the ileocecal area of the intestine. Well, encystation is the conversion of trophozoites to cyst. Now, encystation usually occurs if there is a change in the environment that will make the protozoa unlikely to survive. Now, the first parasite that we'll be covering is the pathogenic amoeba, the Entamoeba histolytica. The trophozoite of the Entamoeba histolytica, it is the active vegetative state, and this is the pathogenic stage of the Entamoeba histolytica. It is found in lumen and crypts of colons and other tissues. It is usually with a pseudopodia. Yes, they are with pseudopodia, and they measure around 10 to 60 microns. They have this characteristic rapid unidirectional movement, and the pathognomonic sign of Entamoeba histolytica is the presence of red blood cell inclusion bodies, because Entamoeba histolytica engulfs red blood cells. This is what makes it pathogenic. Okay, among the amoebas, Entamoeba histolytica is the most pathogenic and most clinically important. The trophozoites have several parts. They have caryosome, which is the small central mass of chromatin, the peripheral chromatin, which is the chromatin that surrounds the caryosome, and the cytoplasm, which is characterized by a finely granular cytoplasm. So the nucleus of the trophozoite has the central caryosome. It is made up of chromatin, while the peripheral chromatin is located at the nuclear membrane of the nucleus of the trophozoites. So as you can see here, the trophozoite of the Entamoeba histolytica, in terms of its nucleus, it contains a central caryosome and a peripherally distributed chromatin. Again, another illustration of the Entamoeba histolytica trophozoite. Make sure you are familiar with the illustration. And also, this one shows you the Entamoeba histolytica trophozoite. So, make sure that you need to have the pictures of the trophozoites and cysts of the parasites, because it is important again in diagnosis. Here you see several red blood cell inclusions, and this is pathognomonic of Entamoeba histolytica. The cyst of the Entamoeba histolytica is the infective stage of the parasite. The trophozoite is not the infective stage. It is only the pathogenic state. So if you take in trophozoites of Entamoeba histolytica, you won't be infected. And why is that? Because trophozoite do not have that thick outer covering that will protect from harsh environment, especially in the stomach. The stomach has high acidity, while the cyst has this thick cell wall which protects them from the harsh environment. So this is the infective stage of Entamoeba histolytica. It is quadrinucleate, meaning it contains 4 nucleus. It is spherical to round, measures around 10 to 20 microns. It contains the glycogen vacuoles and chromatoidal bodies. The cyst contains the chromatoidal bars or chromatoidal bodies. And the cyst of Entamoeba histolytica is characterized to have a chromatoidal bars having a squared or round-ended structure. And these structures contain dense RNA material. Red blood cells, bacteria, yeast, and other debris are not found in the cyst stage. They are found only in the trophozoite stage. Please do take note that differentiation between Entamoeba histolytica and Entamoeba coli is not possible by microscopy, meaning they have the same morphologic features. Therefore, when we see a typical specimen, a typical morphologic feature or typical clinical specimen that contains trophozoites and cysts of histolytica, we usually report as E. histolytica / E. dispar trophozoites or cyst. So we can differentiate E. histolytica and E. dispar through molecular methods. The cyst of Entamoeba histolytica is characterized by the presence of quadrinucleate cyst, 1, 2, 3, 4, and the chromatoidal bars. It's rounded end. It has a rounded end on each portion of its part. Okay, as you can see here, there's a rounded end of the chromatoidal bar. So that is very typical of Entamoeba histolytica. Okay. Again, this shows you the Entamoeba histolytica cyst. So the chromatoidal bars, it's rounded end, and you have quadrinucleate cyst, 1, 2, 3, 4. This is very obvious. You have 1, 2, 3, 4, and a rounded end chromatoidal bars. Okay, this is another illustration. And Entamoeba histolytica is notable to cause amoebic colitis. Now, this illustration shows you how Entamoeba histolytica affects our large intestine. As you can see here in the left, the lining of the colon is erythematous, meaning it's red because it has inflammation. And this is the usual histologic picture showing you the invasion of trophozoites through the intestinal wall. Greenish fecal matter, usually it's soft to watery, greenish with blood or mucoid in the stools. This is a usual clinical specimen containing Entamoeba histolytica. So as you can see here, it's mucoid. It's greenish to yellowish with blood streak. Why is there blood streak? Because as you can see in the histologic slide, there is ulceration. The mode of transmission is through fecal-oral route. It's the ingestion of contaminated food or water with mature quadrinucleated cyst. Sexual contact can be one possible mode of transmission through anogenital or orogenital tract, especially to those individuals who partake in high sexual risk behavior, such as men having sex with men. Vectors can also be a cause of transmission, such as the flies and cockroaches. They can carry fecal matter with cysts. Now, what happens during infection? So, an infective form or quadrinucleated cyst is ingested. It goes into the esophagus, then to the stomach, and then it goes into the small intestine. And in the small intestine, it is where excistation of the parasite occur. Again, what is excistation? This is the conversion of cyst to trophozoites. Now, once cyst is converted to trophozoite, it then travels to the large intestine, in which the trophozoite can cause colitis or inflammation of the colon. Okay. Now, in the inflammation site or where the trophozoite would elicit or would incite inflammation to the site of infection, it has the ability to invade through the intestinal wall, again because of the cystine proteinases. Now, that trophozoite when it encounters a harsh environment, it undergoes encystation. So encystation occurs in the large intestine, and it's the conversion of trophozoites to cyst, and then it travels out through the fecal matter as cyst or trophozoite. So, Entamoeba histolytica can manifest in various ways. Most common is the asymptomatic cyst passer, in which the trophozoites does not cause any lesion and they transform into cyst and are excreted in feces, meaning the patient has no symptoms at all, but the patient is a carrier. They still pass out cysts that are potentially transmittable to one person, making them infectious. Amoebic dysentery is caused by the proteolytic enzymes that causes destruction and necrosis of tissue and produces flask-shaped ulcers on the intestinal mucosa. Very characteristic in Entamoeba histolytica is the formation of the flask-shaped ulcer. I am pretty sure that you're all familiar with Erlenmeyer's flask. That is the usual shape or configuration of the ulcer caused by Entamoeba histolytica. As you can see here in the illustration in the right, you see that the neck of the ulcer is narrow and you have a broad base. So this is the very typical appearance of the Entamoeba histolytica ulceration. This is in contrast to Balantidium coli ulceration, in which you have a broad neck and a broad base. Again, in Entamoeba histolytica, you have a narrow neck and a broad base, but for Balantidium coli, you have a wide neck and a broad base. So, for Entamoeba histolytica, you have an Erlenmeyer flask-shaped ulcer, while in Balantidium coli, you have a beaker-like shaped ulceration. Amoebic liver abscess can also occur. So, you have extensive erosions and necrosis of the small intestines or the large intestine, in which they are capable to enter into the portal veins and eventually in the liver. So what are the factors that would induce cyst formation? So these are the factors that will induce encystation. We have food deprivation, overcrowding, desiccation, accumulation of waste products, and cold temperature. Desiccation is drying up of the environment. The trophozoite of the E. histolytica is a major invasive form and possesses many virulence factors that may play a role for the pathogenesis of the intestinal as well as in extraintestinal amoebiasis. The virulence factors of Entamoeba histolytica include the amoebic lectin antigen, which is the principal virulent factor, and I want you to read further about amoebic lectin antigen. For amoeba pore, it inserts ion in the target cell membrane. The cystine proteinases, we have discussed this previously, it is secreted by the trophozoites of Entamoeba histolytica. Several hydrolytic enzymes that causes destruction of the target tissue, and neuraminidase and metallocollagenase, they also help in invasions. So we have several enzymes that would break down the connective tissues of our intestinal lining, thus they're capable of invasion. So amoebic ulcer, I've mentioned this. You have a flask-shaped ulcer, which is the classical ulcer caused by the amoebic colitis. The ileocecal region is the most common site. You have a sigmoido-regional region or generalized region. But if you are asked what is the most common or where is the most common site of intestinal amoebiasis, it's usually in the cecum. Now, the cecum is the first part of the large intestines. The amoebic ulcer is scattered with intervening normal mucosa. They may have a superficial or deep ulcer. The size of the ulcer can be as small as a pinhead to inches. The shape is round to oval, the margin is rugged and undermined, and the base is formed on a muscle coat. We have several complications of intestinal amoebiasis. These are the fulminant amoebic colitis, amoebic appendicitis, intestinal perforation and amoebic peritonitis, toxic megacolon, and intussusception, amoeboma, this is amoeboma not amoeba, or amoebic granuloma, and chronic amoebiasis. So for fulminant amoebic colitis, this is the generalized necrotic involvement of the entire large intestine. Most commonly, they occur in immunocompromised patients. For amoebic appendicitis, this is the infection of the amoeba to the appendix, causing inflammation and obstruction of the appendiceal lumen, causing increased luminal pressure, and eventually necrosis of the wall of the intestine, resulting to inflammation. Intestinal perforation and amoebic peritonitis can occur if the ulcer progresses beyond the serosa. Now, there are several layers of the intestines. Now, remember the layers of the intestine? The innermost layer is the mucosa or the epithelial lining. We have the mucosa layers and the serosal layer. The serosal layer is the outermost layer. If the ulcer reaches the serosal layer, it will result into perforation. Toxic megacolon and intussusception. In this intussusception, this is where a segment of intestine invaginates into adjoining intestinal lumen, and this will potentially cause bowel obstruction. Amoeboma, again, is a amoebic granuloma. This is a diffuse pseudotumor-like mass of granulomatous tissue found in the rectosigmoid colon. It usually presents as a mass, and this will make the gastroenterologist or physician think that the patient may have colon cancer, but in reality, it's just an amoeboma. Chronic amoebiasis is characterized by thickening, fibrosis, and stricture formation with scarring and amoeboma formation. When you say strictures, these are fibrotic structure or strands, fibrotic strands that may potentially result into obstruction. Now, extraintestinal amoebiasis is also notable. We have 5 to 10% of individuals who develop this condition following 1 to 3 months of intestinal amoebiasis. The liver is the most common site. And why is this possible? It's because the drainage of our intestines will eventually lead to the liver. Okay? But other sites of extraintestinal amoebiasis have been documented, such as in the lungs, brain, genitourinary tract, and the spleen. Most common group affected of the amoebic liver abscess are adult males. You have 9:1 male to female ratio. The posterior superior surface of the right tube of the liver is the most commonly affected, and the abscess is usually single and rarely multiple. So, what happens during amoebic liver abscess? We have amoebic trophozoites that occlude hepatic venues, leading to anoxic necrosis of hepatocytes, causing inflammation and then abscess. Microscopically, these are the appearance of amoebic liver abscess. You have an inner central zone of necrotic hepatocyte without amoeba. You have a middle zone of degenerative hepatocytes containing red blood cells, few leukocytes, and occasional amoebic trophozoites, and the outer zone of the liver abscess comprised of a healthy hepatocytes that are invaded with amoebic trophozoites. So therefore, if you want to check on amoebic trophozoites, you check at the outer outer zone of the abscess, not the middle zone. Very characteristic of amoebic liver abscess is the formation of anchovy sauce pus. It's thick, chocolate brown in color, usually acidic, comprises of necrotic hepatocytes without any pus, and occasional amoebic trophozoite. So what are the complications of amoebic liver abscess? So amoebic liver abscess is the complication of amoebiasis. Now, these are the complications of a complication. So, we have granuloma cutis, pulmonary amoebiasis, which is the rupture of the right-sided liver abscess and can travel to the lungs, amoebic pleuritis, the rupture of the right-sided liver abscess into the right pleura, subphrenic abscess, and generalized peritonitis. So, when you say subphrenic, it's located under the diaphragm. Phrenic means diaphragm. Amoebic pericarditis, the pericardium is the covering of the heart. So they, in terms of proximity, the pericardium is just superior to the liver. So, by virtue of proximity and contiguity, it's really possible that the amoeba can travel to the pericardium, traversing the diaphragm. Hematogenously, they can spread to the brain, lungs, spleen, and genitourinary tract. Okay, so I've mentioned about this. This is the summary of the clinical manifestation of amoebiasis. And this table shows you the difference between the amoebic dysentery and bacillary dysentery. When you say amoebic dysentery refers to it is an inflammatory condition of the lower gastrointestinal tract resulting into bloody stools. You have usually bloody stools. So this table shows you the difference between amoebic dysentery, So dysentery that is caused by an amoeba, specifically Entamoeba histolytica. And bacillary dysentery, bacillary means it is caused by a bacteria. So the most common cause of bacillary dysentery is the Shigella. Okay, this is the Shigella. We have the Shigella species of bacteria. So they cause dysentery. So please study this table to show you to make yourself familiar in terms of their difference. So how would we diagnose Entamoeba histolytica or intestinal amoebiasis? Of course, through stool microscopy. Stool culture can be done through a polyxenic and axenic culture. Stool antigen detection or coproantigen. Copro means stool. We have several methods. We have CIEP, ELISA, and ICT. For serologic methods, we can detect the amoebic antigen through ELISA. For amoebic antibody, we can detect through IHA, ELISA, and IFA. For isoenzyme or thymidine analysis, we can also perform this. And for molecular diagnosis, we can perform nested multiplex PCR and real-time PCR. The specimen for choice for sample collection is the stool. A minimum of 3 samples should be collected on consecutive days. Stool specimens should be collected in wide-mouth clean container before administration of interfering substances. Other samples would include rectal exudates or rectal ulcer tissue if you perform colonoscopy to the patient. They should be examined within 1 to 2 hours of collection or preserved in polyvinyl alcohol or methylate iodine or formalin. We can detect the trophozoites and cysts through direct microscopy, through stool microscopy, by direct examination of the stool by saline and iodine mount. If you want to check for the motility of the trophozoite, then you have to perform saline mount. If you want to check the internal structure of the cyst, the best way to perform it is to undergo an iodine mount. Stool or colonoscopy guided biopsy samples. You can use stains like trichome, periodic acid shift, and hematoxylin and eosin stains for biopsy and for histologic analysis. Entamoeba histolytica is indistinguishable of that of Entamoeba dispar and Moshkovsky, with an exception. So culture methods are not routinely used for diagnosis. A polyxenic culture can be made. It has a 50 to 70% sensitivity and 100% specificity. Other culture media used are as follows. For axenic culture, it lacks a bacterial supplement, unlike that of the polyxenic culture. Example of an axenic culture is diamond medium. The advantage of using this axenic culture, it's useful when bacterial flora interferes with the test result. For coproantigen or stool antigen detection, we can perform countercurrent immune electrophoresis or enzyme-linked immunosorbent assay and immunochromatography test. Remember, antigens get denatured by stool preservatives and only fresh or frozen stool samples should be used. So ELISA, this can detect 170 kilodalton of lectin antigen. It has 95% sensitivity and specificity, and ELISA can differentiate between pathogenic Entamoeba histolytica and non-pathogenic Entamoeba dispar, which is lectin antigen negative. Remember, I told you that Entamoeba histolytica cannot be morphologically distinguished from Entamoeba dispar, so you can perform molecular methods and serologic methods such as ELISA. Immunochromatographic test is the simultaneous detection of antigens specific for Giardia lamblia, Entamoeba histolytica or dispar, and Cryptosporidium parvum from stool. It has an 83 to 96 sensitivity and 99 to 100% specificity. Okay. So, amoebic antigen can also be detected. The presence of serum indicates recent and active infection. ELISA can be done using monoclonal antibody specific for lectin antigen with only a sensitivity of 65%. Other various antigens can be detected through serology, but they are not quite common, such as serine-rich Entamoeba histolytica protein or SREP, the lysine-rich surface antigen, and lipophosphoglycan or LPG. Other older methods of antigen detection is the CIEP, coagulation test, and slight agglutination test. Amoebic antibody can also be detected through serology. They only appear in the later stages of intestinal amoebiasis because it takes time for the immune system to make antibodies, specifically the humoral immunity. Various tests to detect amoebic antibody include ELISA, IFA, and IHA. ELISA detecting antibody against lectin antigen shows 90% sensitivity in the convalescent stage and 75 to 85% in the early stage. When you say convalescent, it's usually at the later stage of the infection, meaning the patient is already recovering. So as you can see, the sensitivity goes higher if the test is done on a later stage of the infection. Now, isozyme or zymodyne analysis can also be done. This is very uncommon. We detect hexokinase, malic enzyme, isomerase, and phosphoglucomutase activity of the parasite. And this is important to differentiate Entamoeba histolytica and Entamoeba histospar. The disadvantage for this test is that first, you have difficulty in performing the test, and it's time consuming, and there's a difficulty in terms of technical difficulty in preparing the antigens by culture. PCR can also be made. In this one, we target small subunit ribonucleic acid or ribosomal RNA genes, and we can differentiate this one from E. histolytica, E. dispar, and E. moshkovsky. The sensitivity is nearing 90%, the specificity is 90 to 100%. We can perform real-time PCR or conventional PCR or nested PCR. So again, this is the summary of the laboratory methods in diagnosing amoebic liver abscess. So we can perform microscopy, stool cultures, antigen detection, antibody detection, histopathology, molecular diagnosis, and ultrasound. Okay, this is a very important tool to detect presence of amoebic liver abscess. The treatment of amoebiasis is the drug of choice used is metronidazole for intestinal amoebiasis and amoebic liver abscess. We can also use tinidazole. The difference between metronidazole and tinidazole is their pharmacokinetics. Other measures include fluid and electrolyte replacement and symptomatic treatment. The prevention is as equally as important as treatment. So preventive measures are as follows. We need to avoid the ingestion of food and water contaminated with human feces, and treatment of asymptomatic persons who pass Entamoeba histolytica cyst in stool. There's no effective vaccine licensed for human use. Now let's move on to the commensal amoeba. Several important morphologic characteristics of commensal amoeba that we have to take into consideration: the size, motility, the nucleus, and the cytoplasm. Entamoeba coli is the first commensal amoeba that we'll discuss. Now, its cyst consists of 1 to 8 nuclei, that is in contrast to that of Entamoeba histolytica, which has a maximum of 4 nuclei. Its karyosome is off-center or eccentric, unlike in Entamoeba histolytica, in which the karyosome is at the center. Here in Entamoeba coli, it's off-center or eccentric, meaning it's not at the center, right? So, its chromatoidal bars are characterized with jagged heads. They look like broomstick or needle sticks. Its nuclear membrane is thick or irregular, in contrast to that of Entamoeba histolytica that has they have a regular nuclear membrane. For trophozoites of the Entamoeba coli, they have blunt and rounded pseudopodium. And cytoplasm is filled with vacuoles, bacteria, and undigested food. They have a slow and non-directional movement. They have no ingested RBC for the trophozoite. Again, the pathognomonic for Entamoeba histolytica is ingested RBC. The rest should not have any ingested RBC. So all the commensal amoeba do not have ingested red blood cells. So this is the typical characteristic of Entamoeba coli cyst. Please be familiar with this, as well as the typical trophozoite characteristics of Entamoeba coli. So as you can see here, the cyst of the Entamoeba coli consists of more than 4. They can even reach up to 8 nuclei. So if you see a slide containing a cyst with lots of nucleus, most likely that is Entamoeba coli. For the trophozoite, you can see here that its caryosome, it's not at the center but it's eccentric. It's off center. Eccentric means off center. And try to take a look at their nuclear membrane. The nuclear membrane consists of a chromatin, the peripheral chromatin that is irregular and not evenly distributed. Now, this table shows you the difference between Entamoeba histolytica and Entamoeba coli. It's already summarized, so please study this one. For Entamoeba hartmanni, it's smaller than Entamoeba histolytica. They are very thin. They have a very thin peripheral chromatin and they have a centrally located caryosome, just like in Entamoeba histolytica. For Entamoeba puleki, they have a dirty-looking cytoplasm and they are usually found in animals. For Endolimax naina, it's a very characteristic feature of a bullseye appearance of a nucleus. They have a large, centrally located caryosome. It is similar in Entamoeba histolytica that it has a central caryosome, but for Endolimax naina, the caryosome is large. It has a clear area around the caryosome, and they are also known as the crossed-eyed cyst. For Iodamoeba buchli, it's similar to Endolimax naina. However, they have a larger glycogen vacuoles. That is a notable characteristic. This is the glycogen vacuoles. The caryosome is also centrally located and large, just like in Endolimax naina. And only notable here, it's large glycogen granules. Okay. So here you see a glycogen body. This is the glycogen of Iodamoeba buchli. You see the caryosome is large as well. This is very notable, Iodamoeba buchli. Now, this table shows you the summary of the commensal parasites as well as the E. histolytica. If you have a better table, then you can do so. Also, if you have other added characteristics, you can do so. So that you can compare these protozoans from one another, so that you have a bigger picture of their comparison. So make sure that you know their comparison as well as their similarities. Okay. So I just lifted this from other references. You can also make this as your guide in their differences. So it would be easier for you to identify what parasite we are entertaining if we have our cases. Now, I lifted this illustration from the WHO guidance on laboratory diagnosis of parasitic infections. So this can also help in determining what type of parasites that we are dealing. So this is for the trophozoites and these are for the cysts.